evening to you all. I warmly welcome everyone in the audience, including Professor Malik Piris, to this session on COVID-19, the title of which is Diagnosis, Transmission, Pathogenesis, and Prevention. And the audience comprises consultants, physicians, and other specialists in various fields. And I'm sure you must be eagerly awaiting the session. And then I'm Dr. Harsha Sathishchandra, physician at the National Hospital. Professor Malik Piris is chair in virology at the School of Public Health in the University of Hong Kong. He's also a clinical and public health virologist. His special interest is in emerging viral diseases, especially those in the animal and human interface. And he has done a lot of work on influenza, coronaviruses, and actually he played a pivotal role in the 2003 SARS epidemic, and he was instrumental in identifying that the epidemic was due to a coronavirus, a novel coronavirus. And he has over 650 peer-reviewed publications in reputed journals. And he co-directs quite a few WHO reference laboratories in the University of Hong Kong. Coming back to his Sri Lankan links, before he left our shores, he was actually a senior lecturer in microbiology at the Peradeniya University. So we are indeed very proud of your achievements. And may I kindly invite you to share your thoughts and experiences with us today. Over to you, sir.
Thank you, Dr. Hatish Chandra. So firstly, congratulate or sympathize with all of you for being so dedicated to spend the whole Sunday evening listening to discussions on COVID-19. I'll try to summarize some of the recent literature on diagnosis, transmission, pathogenesis, also some of the treatment evidence for and against, and also the vaccines which are now coming online. When this outbreak started, obviously, there were many questions, and one of the questions was, how transmissible is it? So we collaborated with some of our colleagues in mainland China and looked at a case series from them, and looking at the quantity of virus, or the CT value, as you know, in the PCR, the lower the CT, the higher the viral load. So you can see this pattern of the viral load being maximal at the time of onset of symptoms. And now we know even before the onset of symptoms, and then gradually coming down. So this is the pattern that you also see with influenza viruses, but very different to the pattern that you see with SARS of 2003. So we already came to the conclusion that this virus is going to be very efficiently transmissible. And indeed, that proved to be the case. So this is a study that was done by my colleagues in the epidemiology colleagues in our School of Public Health in collaboration with China CDC, looking at a large case series from mainland China. And what you see here is the pattern of infectiousness. So you can see that about 44% of transmission is taking place before the patient develops symptoms. Develops symptoms here at day 0 here. So this is before developing symptoms. And then a lot more of transmission is taking place within the next 3 or 4 days after the onset of symptoms. So this is really the time that most of the transmission is taking place, before the onset of symptoms to 4 or 5 days after. And now there are many other data, for example, through contact tracing, large numbers of people who have been contact traced. And again, the evidence is that the transmission is really taking place within the first 4 or 5 days after onset of symptoms. So that's important to understand. The second thing is, you have this iceberg of infection, which shows that only a very small proportion of patients are severely ill. The majority of patients are mild or asymptomatic. And this again is very different to the pattern with SARS, where most of the patients were severely ill and symptomatic. So these two things, that is the transmission taking place even before the patient is symptomatic, and the fact that a lot of patients are mild or asymptomatic and who may not even be diagnosed or detected, means that this infection is extremely difficult to control. Now, how is this infection transmitted? As you know, it's transmitted by the respiratory route. And we know that there are 2 main types of respiratory transmission. that is large droplets that generally fall to the ground within 1 or 2 meters, and then very small airborne particles which dry out and can spread for longer distances. And so in that regard, we did carry out a study, and this was done on seasonal coronaviruses. This was done before this year, before the emergence of COVID-19. And with the seasonal, as you know, there are 4 other human coronaviruses that commonly infect humans, right? So in those patients, we could detect both these large respiratory droplets coming from their mouths when they breathe, and also the fine airborne particles. And what was most important in that study was when these same patients wore surgical masks, the release of these infectious particles was largely stopped. So this was one of the key bits of evidence, together with the fact that infection can take place from people who are pre-symptomatic, meaning they have no symptoms, or asymptomatic. So it was these 2 things that led to the recommendation for the wearing of some form of face covering when people are going out where they cannot maintain a minimum distance, and particularly when they are indoors. And now there are other studies. For example, this is a study from Germany where they have looked at the transmission rates. And this is the point at which they introduced mandatory masking, or mandated that everyone who is outdoors or who is, out of their home in crowded places or indoors and public transport, etc., do wear masks. And you can see the impact of that intervention. Whereas this is the assumed line that it would have gone in the absence of that intervention. So clearly, the wearing of face coverings does reduce transmission, but it is not 100%. I mean, obviously, nothing is 100%. Now, there is also, of course, another potential route of transmission, and that is through the indirect or fomite route. So somebody who is breathing or coughing particles which drops on a surface, maybe a table or maybe your hands, you may touch something, or you may transfer that to somebody else, or somebody else may touch the surface that is contaminated. And then if you touch your eyes, nose, or mouth, you can transfer infectious material through that route. So this is the indirect route of transmission. And again, this is probably an important route of transmission. Now, one thing that is that was important in this regard is how long the virus survives on these surfaces. And this again is a study that we did in the early weeks and months. And you can see that on smooth surfaces, say for example, stainless steel, a smooth plastic surface, the virus can survive for many, many hours live. I'm not talking about PCR positive. PCR positive is not relevant. What you're talking about is, can you culture the infectious virus? And you can. On the other hand, on things like cloth or wood or paper, the virus is very rapidly inactivated. So that again is important, because it does suggest that smooth surfaces such as stainless steel may be a vector for transmission through the hand to the respiratory route path. And just for comparison, so here you can see the virus surviving for 50 hours, 70 hours. You compare that with influenza, within 1 hour, the same dose of influenza would be completely dead. So you can see why this virus can be potentially much more problematic through the indirect route of transmission. Now, of course, for indirect transmission to take place through surfaces and through your hands, the virus also has to survive on your hands, on the skin of your hands. Now, your skin does contain a lot of antimicrobial compounds which rapidly kill many bacteria and viruses. But this is a study that was done in Japan, quite a complicated study. I won't go into the details, but the bottom line is you can see these two graphs. And this is the survival of SARS coronavirus 2 on the skin. Again, you can see it survives for quite a long time. And this is influenza. So again, even on the skin, the virus can survive for a period of time. So taking all these together, it really means that the routes of transmission are through the airborne route, large droplets, small droplets. Now, of course, when you talk about fine droplets, people say, oh, well, this means it can transmit 30, 40 meters. So what is the point in having the distance of 1 meter or 2 meters? But that is not completely true. I mean, it is true that these fine airborne particles, once they dry out, can float in the air for a long distance. But you can see that the concentration of these infectious particles rapidly dilutes out from the time it leaves the patient's mouth. So within a meter or two, you still will get a significant dose of infection. Keep in mind that one virus particle is not sufficient to initiate infection. Indeed, recent studies suggest that the infectious dose, the minimum infectious dose, is about 1,000 infectious virus particles. So, so this is why the distance still matters, even if the virus can be carried in these fine airborne particles, which in theory can spread over a long distance, but because of the dilution effect, the actual transmission is taking place over a fairly short range. And as I pointed out, of course, the wearing of face coverings will reduce transmission by stopping transmission from infected people, as well as protecting you from getting infected to some extent. And I gave you the evidence for believing that hand hygiene also is important. So this is the scientific basis for recommending these measures, which is keeping the distance, wearing of face coverings, and hand hygiene in reducing transmission. Right. Now, this again is another study that was done in Hong Kong, and out from a large number of patients who were contact traced. Essentially, what they found is that most of the patients, like these ones, may be transmitting to one other person or no other person. And there's a small number of people, like this guy, who was transmitting to large numbers of people. So these are these super spreading clusters. So basically, about 80% of the infections really don't lead to major transmission. But a minority of infections, 10 to 20% of infections, are the ones that lead to transmission of any significance, and a much smaller number lead to these explosive spread of transmissions. And the places where transmission takes place are particularly indoors for the reasons I told you, because again, you have the dilution effect if you're outdoors, which reduces the risk of transmission. At the wrong time, meaning when the person is most infectious, that is just before symptoms and the few days after onset of symptoms, and talking loud and singing, and of course, coughing or sneezing, all these will generate airborne particles, which can be quite transmissible. Now, as you know, there are physical distancing measures that have been introduced in many countries across the world, and these do work. And what you see here is actually the data on influenza in Australia. So as you know, in most countries, including in Sri Lanka, but in countries of the southern or northern hemisphere, the influenza is very seasonal. So this is the data for Australia. You can see year after year, every year they do have influenza outbreaks. But this year, you can see this black line. There has been no influenza, hardly any, detected in Australia. And the reason is because the social distance, the physical distancing measures that have been put into place for COVID-19 do have an effect on all respiratory viruses. And indeed, talking to many physicians here in Sri Lanka, people do observe that respiratory infections overall have declined quite dramatically. Now, of course, one of the side effects of this is that the population is probably building up a susceptible group of people to influenza at some point. So we may have big influenza outbreaks in the future as well. Now, I was talking now about transmission, but there's another question of the duration of infectiousness after a person has developed symptoms. Now, I already gave you some evidence suggesting from the epidemiological point of view that the duration of infectiousness is relatively short, maybe 5 days or thereabouts, or a bit longer. And this is evidence from virus culture. So this is, again, a cohort of patients in Hong Kong, because like in Sri Lanka, in Hong Kong, we were isolating patients, symptomatic or asymptomatic, in hospitals until there were 2 negative PCR tests. And this is the reason why we did this study was because there were so many people who are recovered from infection, from disease, who were just being locked up in isolation because they were waiting for these 2 PCR tests that to be negative. And you can see some of these people are positive for long periods of time, 40 days here, 50, 60 days PCR positive. And this is the viral load. And you can see some of these patients actually having quite high viral load as well. So the real question was, are these people infectious? So what we did was to try to culture the virus from all of these patients. And what you can see, these black crosses are, these are PCR positive, and the viral load is shown on this axis. Going up is greater virus load. But the red circles are the ones where we could actually culture infectious virus. So basically what we were able to show is that even though PCR may be positive and may be positive at quite high load for many, many days or many, many weeks, virus infectiousness has more or less gone by day 8 or day 9. So, and now these findings have been confirmed by other studies in the UK, for example. The bottom line from here is that PCR positive does not equate to infectiousness, right? So the infectiousness, particularly in asymptomatic and mild patients, by day 8, day 9, they are no longer infectious. And this is why Sri Lanka, as well as in Hong Kong, we changed our guidelines for patient discharge, that after, in Sri Lanka, I believe it's 14 days, in Hong Kong it's 10 days, after onset of symptoms or after the first positive PCR test result, as long as the patient is clinically fit and recovered, the patient can be discharged without even a PCR test, or definitely without waiting for 2 negative PCRs. Now, there are, of course, a subset of individuals, obviously, if you're immunocompromised and if you're severely ill, then you may be infectious for a longer period of time. But again, most patients, even the severely ill, by 20 days after onset of infection, infectious virus is not detectable. But if you're very severely immunocompromised, that is T cell, B cell defects that are complete, then of course the patient may be infectious for a much longer period of time, but that is very exceptional situations. Right, so this now puts into context what I was telling you. So if you look at this as the amount of virus, maybe let's say this is the PCR viral load. As I said, it starts to rise just before onset of symptoms. It's peaking before onset of symptoms and remains high for the next few days. And then it drops, but then the PCR can be positive for a much longer period of time. Now, the infectiousness is only during this period where there is high viral load and within the first 7 or 8 days after onset of infection. Later on, the patient may be PCR positive, but the person is not infectious. And of course, in related to this is the fact of the role of the antigen detection test, the rapid antigen test. Now, the rapid antigen test, if you look at this whole time course of infection, during this phase of the infection, the rapid antigen test has quite good sensitivity. If you look at patients in this phase of the infection with low viral load, the rapid antigen test has very poor sensitivity. So if you're just taking, PCR positive specimens, the antigen test may be very poor. But if you are looking at patients within the first few days after onset of clinical symptoms, and you're looking at patients with high viral load, the antigen test can be very effective at picking up the vast majority of them. And of course, as you know, the result can be much faster, and it can be applied, can be performed in a much wider range of facilities and laboratories than the PCR test. And now this is, for example, another paper recently where they're looking at this issue of test sensitivity, turnaround time of the test, and the frequency of testing. This is for a slightly different purpose, which is for population screening. But what they conclude from this modeling study is that test sensitivity is not the only or the most important thing. Turnaround time to getting a result back in the epidemiologist or the clinician's hand is very important, because it is no point having the most sensitive test in the world if it takes 5 days for the result to get back to you. Maybe if you're trying to isolate the patient, you're probably infected, half the people in the ward. Or if you're trying to contain a chains of transmission, again, it is you have lost the chance for stopping transmission. So I think you have to think of the right test to be used in the right place. Now, certainly, if you have a patient in front of you whom you highly suspect to be COVID-19 and you want to make a diagnosis, PCR is the most sensitive test. And if the patient is already in isolation, that is fine, even if the test takes a day or 2 or 3 to come back. But if you are making decisions about isolating, not isolating a patient, then waiting even 1 day can be too long, and waiting 5 days definitely is too long. Now, in terms of the infection fatality risk, as you know, age is a very, age and sex are very heavy predictors of disease severity. And this is data not just from diagnosed cases, this is based on detecting people in the population by antibody testing, and then looking at the fatality risks with age. And you can see that from age 60 onwards, you have a very steep increase in the case fatality risk, the risk if you get infected of you dying from the infection. And again, in the case of men, the risk is higher than for women. And as you know, of course, there are other comorbidities that increase the risk, cardiovascular disease, respiratory disease, but not asthma and sleep apnea. But other underlying respiratory diseases, renal diseases, liver disease, diabetes, cancers, etc., also increase the risk. But age and sex are much more important than any of these. Now, in terms of pathology, the pathology of this is primarily the lung pathology, which is that of acute respiratory distress syndrome, similar to what we saw with SARS or with severe influenza or other viral respiratory pathogens. But the one difference, of course, is that microvascular involvement and microthrombi, sometimes leading to hemorrhage, and sometimes, as you can see here, even thrombosis in large blood vessels, as you can see here, can be quite important in the pathology and the fatality associated with this disease. Right, so I want to now get to clinical management or treatment, and this is just a schematic of what we think is going on. So once a patient gets infected, you initially have high levels of virus replication, and this is, of course, you can have direct damage of the virus on the respiratory epithelium. But then this settles down because the immune response gradually begins to control the virus infection. But then what can happen is that a host inflammatory response, which hopefully should be controlling the infection, in some patients becomes hyperactive, and that can begin to cause pathology as well. So this is why management of these patients, in addition to the symptomatic management, symptomatic care, of course, we are looking for antiviral therapies, but also managing this inflammatory response becomes important. Now, I'm not an intensive care specialist. I'm not an intensivist. So I'm just giving you the data, and this is from WHO, their recommendations, which I'm sure you're well aware with. Uh, the use of supplemental oxygen therapy, if you are using mechanical ventilation, using lower tidal volume ventilation, using conservative fluid management, etc. This is all there in the WHO guidelines, and there is no disagreement with these. Recognizing septic shock and using low molecular weight heparin in high-risk patients at high risk of clotting. But what about the specific treatments for COVID-19? And of course, as you know, there has been a lot of controversy, a lot of argument about these, and I'll just try to summarize where we are with these. And I'm sure you'll agree that in this type of situation, where 98% or thereabouts of people recover from this infection, it is extremely important to do proper randomized clinical trials, because otherwise there is no way of knowing that what you're giving, the patient is likely to get better anyway. All right. So unless you do very carefully controlled trials, it is not possible to make any conclusions from observational studies that you gave this and the patient got better. So what is the data that we have from randomized clinical trials? You have heard about remdesivir. Now, I'm aware that many of these drugs are not available in Sri Lanka, but I'm just giving you the available information anyway. So remdesivir, the consensus is that it shortens the time to recovery, but there doesn't seem to be a significant mortality benefit, or at least the WHO trials did not show a significant mortality benefit, improvement in mortality. Favipiravir, again, the data is inconclusive. And with favipiravir, I can also tell you that in the test tube, favipiravir does not stop viral replication. Now, most of these other things, like remdesivir and some of the other things I'm talking about, at least in the test tube, it does work. But favipiravir does not even work in the test tube, although I'm aware that there are some controversial trial data which does suggest it reduces viral load. Convalescent plasma, so this is plasma taken from recovered people, infused back into sick people. Again, the data is not at all promising. Of course, chloroquine, hydroxychloroquine with or plus or minus azithromycin has been hotly debated. But again, the clinical trial data from the UK, the recovery trial, the WHO trials, many trials essentially finding no clinical benefit. IL-6 is a cytokine, and now we are getting to the host response modifiers. So drugs or antibodies that block the IL-6 signaling pathway have been tried, but again, no conclusive evidence of benefit from these. These monoclonal antibodies, for example, the ones from Regeneron, it does seem to reduce viral load and symptoms in outpatients, but again, the definitive clinical trials are awaited. So out of all these, the one thing that has shown significant clinical benefit, and thankfully something that is available widely, including in Sri Lanka, is systemic corticosteroids. And this does have a reduction in mortality, which is extremely important, but in appropriate groups of patients. So this is the data from the UK recovery trial. And what you can see here are patients who were on invasive mechanical ventilation, on oxygen, and those who did not require oxygen. So you can see that patients who required mechanical ventilation, dexamethasone treatment did improve mortality outcomes. Patients who were oxygen dependent also had a benefit, but the extent of benefit was much more modest. But importantly, the patients who are not oxygen dependent had no statistical benefit. But indeed, if you look at this carefully, you can see that the dexamethasone treated group may be doing slightly worse, although this was not statistically significant. So the point here is that yes, dexamethasone and other corticosteroids do have a survival benefit in severely ill patients, but we should not be giving it to all patients from the time of presentation, irrespective of their clinical state. Now, this is a meta-analysis of many studies that have been done with systemic corticosteroids, dexamethasone, hydrocortisone, methylprednisolone. And again, the conclusion, so you can see this red line means no effect. On the right side of the red line means it is a bad effect. The left side of the red line means that you have a beneficial effect. So you can see that most of these studies are having a beneficial effect, and many of them are also statistically significant, meaning the 95% confidence intervals are not crossing the 0 point. So definitely the consensus, the weight of evidence is that corticosteroids are beneficial for that particular subset of patients who are severely ill. Now, there is some theoretical data from understanding the pathology of these patients that supports this separation of the type of patient who will benefit from corticosteroid treatment. Now, of course, you have heard that about cytokine storm and that COVID causes cytokine storm and all this. So in this particular study, what they did was they took 78 patients with COVID. So no, actually 78 plus 86 patients with COVID, and they compared it with 26 patients with severe influenza and 15 controls, and did very detailed cytokine studies in these patients. And what they found is that these patients have a profound suppression of interferon responses. As you know, interferon is one of the protective cytokines. And then in the overall patient group, they saw two distinct immunological profiles. There was a minority of patients, actually 4% in this particular study, with extreme hyperinflammation, or in other words, cytokine storm. The other patients actually had lower levels of cytokines than even patients with normal flu. So it is not correct to think that all patients with COVID-19 have cytokine storm. There is a subset of people who seem predisposed to this serious complication of cytokine storm, but the vast majority of these patients do not, and indeed they have hypo-responsive cytokines. And this is exactly why, if we go around treating everybody with corticosteroids, we would end up with doing more harm than good. And this again highlights the importance of doing careful, controlled, randomized clinical trials, because only then can you identify the subset of patients, first and foremost, whether the intervention is effective or not, and the subset of patients in whom it is effective. Now, very quickly, I won't go into the details here, but now there is now emerging information that there are genetic people who have genetic defects in the interferon system are at risk of much higher mortality with COVID-19. And indeed, another part of this defect in the interferon system is autoantibodies. So there are people who, for whatever reason, seem to have autoantibodies to interferon alpha, and these patients also do much worse with COVID-19. So again, highlighting the importance of the interferon system as a defense against COVID-19. Now, of course, there are many other studies ongoing where we need more clinical data, and there are trials in place. And very recently, just 2 days ago, there is a study using one of these immune modulating agents, which is this baricitinib, used in combination with remdesivir. Again, you can see an improvement in survival or improvement in recovery in the combination group compared to remdesivir alone. But again, probably not so relevant for many countries, because we don't have access to, certainly to remdesivir in any significant amount. Right, so in the last few minutes, I will talk about viral vaccines, because this is really the area of real hope. So let me just remind you of the background of what viral vaccines are. So as you know, there are different ways that we can develop a vaccine to a virus. you can grow up the virus in large amount, kill it, and inject it. So, for example, the rabies vaccine is like that, or the killed polio vaccine is also based on that. So you basically have all the proteins of the virus. It's injected, and the vaccinee makes antibodies to all the proteins of the virus. And some of these are protective. Another type of vaccine are live attenuated vaccines. Here, the infectious virus is modified in some way to make it unable to cause severe disease, but can still cause infection. So again, we have the measles vaccine, the mumps, rubella, varicella vaccines, the oral polio vaccine. These are live attenuated vaccines. And then a third classical way of making vaccines is to inject a particular viral protein that is crucial for generating neutralizing or protective antibodies. And here we have hepatitis B, and the HPV vaccines are like that. Now, in theory, of course, you can also inject RNA, which will code for the virus protein, or you can inject DNA that codes for the virus protein, and both of these will give rise to the viral protein of interest, and that could theoretically be a vaccine as well. Or alternatively, you can deliver the RNA of interest using another vector, for example, another virus, for example, an adenovirus, where you replace bits of the adenovirus with the RNA of interest, and this adenovirus will carry the RNA into the cell, and the RNA will produce the viral protein. So all these are strategies for delivering the protein of interest to make an antibody response. But these are all new strategies. I mean, this RNA vaccines and the adenovirus delivery vectors are new. Now, so I just want to point out here that because there's a lot of things in social media saying that, oh, these RNA vaccines will alter your genome, it will get integrated into the host DNA, and it will alter your DNA. This is rubbish, full stop. There is no way that RNA can get transferred, converted back to DNA, and RNA per se doesn't get integrated into anything. It gets degraded. I mean, all our cells, all the time, they are manufacturing RNA because our cells are making proteins. And these RNA, after a period of hours, after they do their job, they are degraded. They don't get integrated into anything. So this is one of many false rumors that are going around. So what are the COVID vaccines that are available? As you know, there are two vaccines now, the Moderna and Pfizer-BioNTech, which are RNA vaccines. There are a number of vaccines which use this adenovirus vector system, and this includes the AstraZeneca, a Chinese vaccine called CanSino, the Russian vaccine Gamaleya, and also a Janssen J&J vaccine. All of them use adenovirus to get the RNA of interest, which is to this viral protein, into the cell. But there are differences in the adenovirus they're using. So the Chinese vaccine uses a common human adenovirus, adenovirus 5. Now, theoretically, this would have some problems because many of us are infected with adenovirus type 5, and we have antibodies to adenovirus type 5. So one would predict that people who have antibodies to adenovirus type 5, particularly the older people, are unlikely to be making good antibody responses. And indeed, that is what I believe the clinical trials seem to show with this vaccine. The AstraZeneca vaccine uses a chimpanzee adenovirus. So therefore, there is no immunity in the human population to this chimpanzee adenovirus. The Russian vaccine uses a very rare human adenovirus, adenovirus 26, as the prime, and then they boost with adenovirus 5. The Janssen vaccine also uses this adenovirus 26. So these ones may theoretically would have a better chance of success. Then, of course, you also have the very old-fashioned grow up the virus, kill the virus, and inject it type of vaccine, inactivated vaccine. Some of the Chinese vaccines are based on that approach. And then we have the viral protein. The protective protein is the viral spike, this thing that juts out from the surface of the virus. And this can be used as the vaccine. So there are some vaccines. These are not yet, the phase 3 clinical trial data is not yet out. So what do we know so far? As you know, there's a lot of stuff out in the media, but there are 2 papers that have come out as well. So and the papers already, the published papers are with the Pfizer-BioNTech vaccine. The paper is out, so you can look at the data in detail. The AstraZeneca vaccine, the paper is out. You can look at it in detail. For all these other things, it's basically what you see in the media. But anyway, I have summarized, the information that we have gathered from the companies here. So the point estimate of vaccine efficacy for Pfizer and Moderna is very good, in the 90%. I mean, I must say that's fantastic. The Russian vaccine also claims to be in that range, but the number of events, the size of the trials are much smaller. The AstraZeneca vaccine, the trial has got a bit complicated, as I will explain to you later, but let's say the efficacy is somewhere in the order of 70% or something. And then we have this vaccine here, again, one of the Chinese vaccines, inactivated vaccine, which was tried out in the United Arab Emirates, and they report a efficacy of 86%. Now, the vaccines also have marked differences in the storage requirements. Some of them require ultra-cool storage, particularly the Pfizer vaccine, whereas some of these other vaccines can be stored at more conventional temperatures. So these are also potentially important to consider. And these are, again, some of the prices. And these are not official. This is the best I can find from the information that is available. So you can see some of these vaccines are quite expensive. Right, so just to show you the clinical trials for the 2 published clinical trials. First is the Oxford AstraZeneca vaccine. And this shows the population that was vaccinated. And you can see that that from basically the efficacy was counted from, I think, 14 days after the second dose. And you can see that the rate of infection in the control arm is this blue here. The control was a meningococcal vaccine. And here you see the vaccinated arm. And this is how the efficacy comes out at whatever they calculate it to be. But as I told you, the AstraZeneca trial got complicated because they made a mistake in one of the trial sites where the dose was lower than expected. So here, this is the data from the planned study where they gave the standard dose as a prime and a standard dose as a booster. So this was what they were planning to do. And then the efficacy is only 62%. But this was the accidental mistake they made. So the first dose was a lower dose, half dose actually, followed by the full dose. And in this group, you have a dramatically higher success rate, dramatically higher vaccine efficacy. Now, of course, this is a small group and it's very difficult to know what to make of this. So it will be interesting to see what the regulators make of this. So my bottom line is, I think it is promising, but it's unfortunate. So I think we will need more data from this trial. The Pfizer trial looks extremely impressive. Again, you can see from the time of the second dose, you can see up till about 12 days after the second dose, the control and the placebo, there is no difference as you would expect, because you would take some time. This is after the first dose, and that is very important. So this is after the first dose, the days after the first dose, that you can see the effect. And what you can see really is a very dramatic protective effect. And also the fact that even after a single dose, there is some protection of at least 50%. So that is fantastic news. I mean, obviously one would want to immunize people with the 2 doses as recommended, and that takes it up to 90%. The other very important bit of information from that trial is that the vaccine seems equally effective in all age groups. As you know, the most important age group are the older citizens of the population. And the vaccine does seem to be effective irrespective of age group. Now, what can we expect from these vaccines? Uh, the clinical trial data up to now is basically a very short time after the vaccine is administered. So we don't know whether you will still have the same 90% protection in 1 year, 2 years time. So that's one issue. Second issue is, will the vaccine also protect from transmission, or will it only protect from disease? So it is important to keep in mind that the current vaccine trials, the readout of the vaccine trial is not transmission, obviously, it is protection from symptomatic disease, right? Now, you cannot assume that protection from symptomatic disease means protection from asymptomatic disease or protection from transmission. So at the moment, you cannot necessarily assume that these vaccines will protect from transmission. We hope it does, but that is still left to be seen. So when people talk about herd immunity and the effect of vaccines on herd immunity, that presupposes that these vaccines will also block transmission. So it's important to keep in mind these differences. Now, I think being able to protect from severe disease, particularly in the high-risk groups such as the older population, is extremely important. And I think I'm a strong believer that this vaccine is going to be, or the effective vaccines are really going to be game changers in the COVID fight. But we have to be realistic, and we have to be realistic as to what we expect the vaccine to do. Of course, there are many issues in terms of rolling out the vaccine in regard to educating the public that there are, of course, side effects of the vaccine. You have to judge the side effects and the benefit. But when you start a vaccination campaign, when you're vaccinating thousands and thousands of people, you know that there are rare events that take place in thousands and thousands of people. People will get heart attacks, they will get in traffic accidents, they may have Guillain-Barré, they may have transverse myelitis, they may have got it anyway. So it is quite important to be careful that you don't derail your vaccination campaign just because there's one adverse effect. But equally, it is also important that you have post-vaccination monitoring to pick up any real signal. So this is a real balance that has to be done, and to be done carefully. And I just want to end up with this slide, and I think you will appreciate that managing and controlling this COVID problem is not just a problem to be done at the hospital level. We really have to have communication to the general public, because at the end of the day, control of transmission is in the hands of the public and what they do. So this requires good communication, understanding the social diversity and what type of messaging will persuade different groups of the population. And of course, in today's world with Twitter and Facebook and whatnot, conspiracy theories and total rubbish is widespread. I mean, I've seen such total garbage in terms of many things, including vaccines. So it is very difficult nowadays to give the correct message to the people who need to get the message, and this is extremely challenging. So with that, I will end, and I thank you for your attention. I'll be happy to take any questions. Thank you.
That was indeed a very comprehensive and illuminative lecture, Professor Malik Piris. And on behalf of Professor Tilak Jailath, who's the president of the Sri Lanka College of Internal Medicine and the Council of the Sri Lanka College of Internal Medicine, I must really thank you for accepting our invitation and sharing your thoughts and experiences with us. There are a few questions. I think we would be happy to take them. One is on the infectivity, how it changes with time in asymptomatic individuals. Have we got any evidence for that? In asymptomatic individuals, probably it's difficult to time the illness, but of course, how from the first PCR, how does it vary with time?
Yeah, so it is quite similar to mild infections. There are one or two studies where they have compared. So of course, with the asymptomatic infection, you have to start with the first positive PCR. So you don't know when they first, were positive. But with that proviso, basically the viral load and the duration of shedding is quite similar to mild COVID patients, not markedly different.
I see. Then there's another question on whether the virus could replicate in dead bodies, whether it is possible for the virus to replicate, and whether there's an implication on it contaminating groundwater in say, in case of burial, whether there is any evidence regarding that.
No, I mean, that's a simple answer because viruses can only replicate in living cells. Unlike bacteria, certain types of bacteria can survive and replicate, out in the environment, right? But viruses, by definition, require living cells to replicate in. So once the patient has died and the cells have died, the virus can no longer replicate and the virus will die. So that is point number one. Point number two, as I told you, the period of infectiousness is before the patient develops symptoms and the 4 or 5 days after the patient develops symptoms. That is where most of the infectiousness is. So, I mean, unless a patient dies, at day one after getting symptoms, which is extremely unlikely, by the time a patient dies after 1 week, 2 weeks of infection, the infectiousness is much, much lower. Now, with seriously ill patients, the duration of infectious virus can be a bit longer than the 10 days I told you, but still, overall, the level of infectiousness is much lower. We know that once patients develop antibodies, and again, most people develop antibodies by day 10 or thereabouts, again, infectious is lower. So basically, transmission from a dead body is extremely unlikely, unlike, for example, Ebola. Ebola is a completely different situation where transmission from corpses has been very well documented. But there is no reason to believe, really, that in the case of COVID-19, that a dead body is a major source of transmission. Then, of course, I'm familiar with this business of burial. So let me be clear. I mean, I'm quite happy to be cremated with or without COVID. I don't have a problem. But, I mean, to imagine, first and foremost, I told you the scientific evidence in terms of infectiousness at the time of death, the fact that the virus cannot survive after death. And then if you wrap the body in some impervious, what do you call, wrapping, and I understand people are also talking about putting some chemical in, and you bury the body 6 feet underground, unless you bury the body right into running water, I mean, even if there's any residual infectious virus, that has to filter through many, many feet of soil and get into the water and survive in the water. To be honest, to be frank, I must say this is complete non-scientific arguments. And indeed, this is why WHO and many countries in the world, have no problem with this. Thank you. Yep. Next question.
Yeah, there's another question on the relative significance of transmission by droplets, aerosols, and fomites. Do we have any? I suppose it changes due to circumstances, but what contributes more to, and what is driving the epidemic like pandemic?
Basically, it depends on the context. And as I said, most of the transmission is, we believe, taking place over the short range due to large droplets and aerosols, but aerosol at short range. Because as I told you, the more distance you have from the source, the infectious aerosols are diluted in the air, so the infection dose is less. But having said that, there are clearly some examples of transmission over 20, 30 feet. And these examples have to do, for example, traveling in air-conditioned buses with the windows closed. In that situation, clearly the aerosols may be spread over much longer distance. Or, for example, in a restaurant where the airflow has been in one direction, the infected patient was near the source of the airflow, and people maybe 15 feet at a table, 15 feet away got infected. So there are very specific situations where you can have directional airflow, which can lead to transmission at a greater distance. But the bulk of transmission is taking place at a shorter distance, but also possibly by indirect route, which is fomites. But as I said, it is context dependent. I mean, it depends on the exact situation and the context of the event. Thank you. Over.
Yeah, there's another question on whether there is this phenomenon of antibody-dependent enhancement of disease in COVID-19, like what we see in dengue.
Yeah, so yeah, this has been discussed quite a lot. Now, the dengue antibody-dependent enhancement is a very specific situation because the dengue virus replicates inside monocyte macrophages. So when you have a virus coated with antibody, the antibody can drag the infected virus, infectious virus antibody complex into the macrophage or the monocyte. And therefore, you can actually have greater rates of infection when you have low levels of non-neutralizing antibody. Now, in the case of COVID, the main target of the virus is not the monocyte macrophage. It is the epithelial cells of the respiratory tract or the gastrointestinal tract. Now, these cells don't have FC receptors, so that same mechanism of FC receptor mediated antibody-dependent enhancement of viral replication is unlikely. And indeed, we have tested this ourselves, and we can show yes, you can have increased uptake into macrophages of COVID-19 virus or SARS coronavirus 2, but it doesn't replicate inside the macrophage. So, it doesn't have any adverse consequence. Now, there is another issue, which is, vaccine enhanced disease. Now, with SARS, we did see that with certain vaccines, particularly when the whole virus was included, meaning the protective protein is the spike protein. Now, if you have all the other proteins of the virus, particularly the nucleoprotein, you can get a situation where those are not generating protective immune responses, but they may be generating pathogenic immune responses, particularly cell-mediated immunity. So these have been a major source of concern, but in all the experimental animal studies so far, it has not been seen. So I think this is, if you ask me, in terms of, I would prefer not to take the whole virus vaccine for this reason, because the whole virus vaccine has all the proteins of the virus, the protective spike protein, but also some of the other proteins. But the spike protein predominantly is the main target for protective immunity. And I think the chance, and with the evidence also so far, the chance of enhanced disease, I think, is pretty low. But of course, we have to be alert to these possibilities. Over.
There's another question on the effect of SARS coronavirus 2 on school children. Do we know whether they behave differently when infected, or is it the same?
Yes, so of course, on the one hand, children have very mild infection, right? So they have very mild disease. So from a clinical point of view, they are likely to be asymptomatic. But I think the question is really about transmission. Now, again, there is quite a lot of debate on this issue. There does seem to be some evidence that children are, put it this way, in situations where they have looked at evidence of outbreaks of transmission within schools, it has been relatively little. So there seems to be, some trend to suggesting that children are not as infectious as adults. Now, this is in marked contrast to influenza. With influenza, children indeed are the main drivers of transmission in the community, and particularly to the older parents and things like that. But it's very difficult to completely disprove or to say that it is fine and children are not infectious, etc. But I can only give you the evidence that is there, and the evidence that is there does seem to suggest that particularly younger children certainly are not the main drivers of transmission. That is probably true. It is the young adults who seem to be the main drivers of transmission in most communities, because they are also largely asymptomatic. but they are moving around quite a bit, and they seem to be the main drivers. But I really, yeah, I understand the importance of the question, because the question of opening schools and all this is dependent on this issue. Yeah, over.
Yes, thank you, sir. Then there's this question of, now in Sri Lanka, we have, I think, over 20,000 patients who have recovered from SARS coronavirus 2, COVID-19 infection. Now, when these patients, after being discharged from a COVID hospital treatment center, if they come back with respiratory symptoms and or without symptoms when they present to hospitals with other illnesses, do we need to check their uh, uh, antigen status or the PCR status? Is there any requirement for that? I understand the CDC has said that there's no need to recheck these patients until about 3 months, and there are some reports of reinfection in a very small proportion of patients. So, what are your thoughts on that, sir?
Yes. So firstly, reinfection has been reported in a small number of cases. I'll come back to that in a minute. But to answer your first question first, I mean, should you be checking these patients with PCR, just when they come for, a pain in the leg or something? Definitely not. Because as I told you, some of these patients can be PCR positive for months. I mean, I showed you the data for 60 days, 70 days, and patients positive up to 90 days, I believe. So, what will you do if you find a PCR positive? I mean, it doesn't mean that that patient is either infectious, nor does it mean that necessarily mean that that positive PCR result is having any clinical significance. Now, of course, if the patient's symptoms do suggest a recrudescence, I mean, if the chest X-ray is also suggesting extension of the pathology, or if you really have reason to believe that this may be a COVID-related symptomatology, then you may very well, test the patient again. But then you have two possibilities. One is that the patient is continuing to shed the virus, not infectious, for a long period of time. And you also know that there is this thing called long COVID, where you do have some of the symptoms of COVID persisting for a long period of time. That is one side of it. On the other side, of course, you can have reinfection. But in order to prove reinfection, just finding PCR positive in a patient who again has respiratory symptoms, say for example, does not prove reinfection, because it could be that the patient is still continuing to shed the virus from his first infection. So in order to prove reinfection, as you may know, the very first reinfection that was proved was a patient in Hong Kong. So in order to do that, you had to sequence the virus from the first episode and the second episode and show that they're different, right? So that is the conclusive evidence of reinfection. Up to now, I mean, I think reinfection per se has not been a major problem. There are, I believe, something like 25 or 26 fairly proven instances of reinfection. In most cases, they have been asymptomatic. The reinfection has been asymptomatic, but there are one or two instances where the reinfection has been more severe than the first infection. So I think these are possible, and we need to stay alert to them. But I think you have to be very careful, when a patient comes back with some vague symptoms and you do a PCR again, and the patient is positive, you cannot jump to the conclusion that the patient has been reinfected, or even that the patient's symptoms is necessarily connected with, recrudescence of COVID-19. But again, I mean, these are all issues that we have to think through on an individual patient basis. Over.
Yeah, about healthcare workers, I think they are quite impacted by this COVID-19 epidemic. And when they have had a major exposure, they are usually quarantined for 14 days. Do you think that there is enough evidence now to reduce that period from 14 to maybe 7 or 10, if they're asymptomatic?
Yes. So as you know, the incubation period. So the basis for the period of duration of quarantine is the incubation period, from the time of exposure to time of developing symptoms or developing positive PCR. Right. Now, the median incubation period is around 5 days, right? The earliest can be about 2 days. The median is 5 days. And then, like with any biological system, you have a bell-shaped curve. So the 14 days is the outer limit of this bell-shaped curve. And as you go beyond day 10, day 11, day 12, day 13, the probability is less and less and less, right? So for these reasons, there are many places where they reduce the duration of quarantine from 14 to around 10. And I think, that is, of course, in the case of healthcare workers, you do have to be particularly careful, because obviously if, even a small risk that they may be get infected, you have a big risk of spreading within a hospital. So you have to judge that individual case. But overall, I think it is not unreasonable to reduce the period of quarantine from 14 to about 10 days or thereabouts. But as I told you, you have to judge it on the basis of the potential risk that may occur.
In that instance, would you recommend doing a PCR at day 7 or day 10 before release?
Yeah, so I mean, obviously, it would be important anyway to do a PCR at discharge, right? Because otherwise, you may be, I mean, you can just imagine somebody who has come into contact with a source, and that person is in quarantine. Now, the incubation period for that person may be, let's say, I said on a median is 5 days, but maybe it can be 7 days, shall we say? So that person becomes PCR positive at day 7. And then if you discharge that person without doing a PCR test at day 10, then you're discharging the person at a time of very high infectivity. So when we are talking about discharging from quarantine at day 10 or whatever it is, that is with a negative PCR. I mean, you obviously cannot discharge without a negative PCR. Yeah.
Now, Sri Lanka continues to isolate patients who are asymptomatic once they have a positive PCR. Do you think that it's a strategy that we should continue to adopt going forward? They are, of course, isolated in centers and in low-level hospitals if they are asymptomatic. Does Hong Kong follow the same policy even now, or have they changed?
No. Hong Kong continues to isolate everybody who is positive. PCR or antigen is positive. Is isolated in a healthcare facility, not necessarily in a hospital, just like Sri Lanka. We also have sort of lower level isolation facilities. But the logic is that asymptomatic infections can be infectious, right? So if you're trying to prevent transmission in the community, it is not much of a difference between a mildly symptomatic person and an asymptomatic person in terms of the possibility of transmission. So on that basis, you have to isolate that person one way or the other. Now, if you have good, reliable ways to isolate the person at home, that is then okay. But other than that, I think it is advisable to isolate in some facility, which doesn't have to be a hospital, as you say, but some place where there is good hygiene precautions and prevention of contact with the general public for the period of time.
There's this final question, so you must be exhausted. It's on vaccines actually. What would you think is a suitable vaccine candidate for Sri Lanka? Because I think we, knowing the the health resources that we have and issues with regard to storage of vaccines and all that, what would be the vaccine candidate or candidates that we should sort of try to procure in the coming months?
Well, that is a difficult question. I mean, I think, as you know, I mean, Sri Lanka has joined this COVAX facility, which is the WHO kind of mediated process to share vaccines equitably around all countries, and that is great. But the problem is, when will these vaccines become available through the COVAX facility? I mean, I haven't really heard any good timelines on that. I mean, I suspect that any significant numbers of vaccine availability through the COVAX facility probably will be the second half of next year. Now, if possible, it would be desirable to access vaccines sooner, but then there's a challenge of how you would try to access it at this point in time. As you know, many countries have placed advance orders even before the clinical trial data was known, right? So they took a risk and placed the orders. So many of the companies already have advance orders committed to many places. But having said that, I think, I mean, of course, so I mean, let me put it another way. I mean, it is quite clear that controlling COVID is extremely challenging, right? I mean, even for countries that are trying very hard, I mean, except for places like New Zealand, which is extremely isolated and can shut itself off, it has been extremely challenging. So I think the light at the end of the tunnel is the vaccine. And it's not the solution to all our problems, not by any means, but I think it is one of the tools really that we need to bring this situation under control. So trying to access, explore the options for accessing vaccines earlier than what might come through COVAX, I think is worth considering. But then one has to see what are those options. I don't want to recommend any particular vaccine, but I mean, I personally did recommend to some people that Sri Lanka should volunteer to do some of these clinical trials. That would have been one way of getting hold of some of these vaccines at an earlier stage. But anyway, be that as it may, I mean, all I can say is that COVAX is at least it is something on the horizons, so that is great. But and also it is good news really that, I mean, Sri Lanka is not a particularly aged population. I believe the over 60, 65 age group is about 6 to 8%. So that is the high risk group, and of course some other people with underlying conditions, and of course healthcare workers. So when you add all that, it still is a substantial requirement, but you probably don't have to vaccinate the whole population, the first go round. So, but still, that's quite a significant number of vaccines to secure. COVAX has promised 20% of the population, so that should be adequate. But as I said, the question is, when will that come? So yeah, so this is a difficult question, but I would really, urge authorities to try to explore while banking the COVAX in the bank, but explore other options to see whether it is possible to secure vaccine from other sources in advance. Over.
Yeah, thank you very much, sir, for all those clear answers. I think we've learned a lot from your presentation as well as from the answer that you gave to the questions. And once again, on behalf of the Sri Lanka College of Internal Medicine, its President, Professor Tilak Jayalath, and the Council, I must thank you for accepting our invitation and sharing all your experience with us. And I must also thank the audience that they've been very participating very actively, asking questions. So I hope that I managed to sort of present most of your questions to Professor Pires for his very clear answers. Then I will wind up now and wish you all a very good evening. Thank you.
Thank you.